Welcome to Topic 6.4 of Statistical Design and Planning, Experimental Study Design and Planning. For the last set of study designs, we imagine we understand the patterns of our exposure or outcome of interest, and we're ready to test some hypotheses, so we're taking an analytical approach. We ask again, will the researcher assign the exposure to participants? We believe we might like to test interventions or treatments as exposures and then observe the outcome. Therefore, our answer is yes. The researcher will assign the exposure to participants, so we're going to do an experimental study. Experimental studies are cohort or follow-up studies in which the researcher manipulates the exposure. A sample is taken from the population, and the researcher assigns exposure to some, leading to at least one exposure group and at least one unexposed control group, although there may be more. The researcher chooses the exposure and determines who is exposed through a controlled process, which is usually by randomization, but not always. The researcher then tracks the participants over time to detect the effects of the exposure. Experimental designs might also be referred to as clinical trials, randomized clinical trials, intervention studies, and therapeutic or prophylactic trials used to evaluate treatment methods or prevention measures, respectively. First, we're going to talk about randomized controlled trial designs. If the researcher will be assigning the exposure to participants, we're doing an experiment. But next we ask, are the participants going to be randomly allocated to exposure and control groups? If the answer is yes, we're doing a randomized controlled trial. Randomized controlled trials contribute the strongest evidence to the literature of any study design. Experiments that are randomized controlled trials have greater internal validity than experiments in which the participants are not randomized into treatment groups. Randomized trials can be done at the individual level, like in this example, in which individuals who have anemia are selected from the population, maybe children who are seen in a specific clinic who are diagnosed with anemia, and then randomized to either receive multivitamin powder or to not receive multivitamin powder. Then the individual participants are followed over time to see if there is a change in their anemia status. You may also do a randomized community trial where instead of randomizing individual people into the exposure and control groups, you randomize entire communities or parts of a community to receive the exposure or treatment. This is typically done when changes are made that can affect an entire community, like providing the infrastructure for clean water to a village or to schools in a community, and providing no treatment or change to a control community. In this example, you might be following to detect changes in tooth loss and tooth decay. And here again is another representation of the study design, showing how the eligible participants are randomized into intervention and control groups and then followed to detect adverse outcomes. The randomized control trial is an intervention trial in which subjects are randomized to receive the treatment or intervention or are randomized into a control or placebo group. The levels of exposure to the treatment and control are controlled. The purpose of these studies is to show that any difference in groups are due to the intervention or treatment. Randomization is the ideal means for controlling for confounding in study design, in that the random assignment of individuals to groups should then evenly distribute any characteristics that could affect the intervention that are difficult to measure. Randomized control trials, which we also call RCTs, are considered the most scientifically robust study design. They are the gold standard. This is because randomization helps eliminate the potential effects of confounders and creates comparison groups that are as equivalent as possible at the start of the study. In addition, blinding study staff to the study group of participants or to their assignment helps to reduce bias. The high level of control of confounding through design allows any effects to be attributed primarily to the intervention or treatment, and since the level of exposure is controlled as well, randomized control trials have the highest level of internal validity of any study design. We are permitted to use statements of cause and effect when discussing treatment results from randomized control trials. And random allocation is the cornerstone of RCT design. However, we don't always conduct randomized trials because it is not always ethical or feasible to do so. They're ethical and feasible when the treatments are harmless to the subjects consent to being a part of the study, and the treatment assignment and mode of delivery can be controlled. That is, the researcher can stop the treatment or intervention, and that a person can leave the trial at any time without consequence. If experiments might be potentially harmful or unethical, you cannot do an experiment, and you'll have to find a way to observe nature taking its course with an observational study. Examples of randomized control trials include clinical trials that compare effectiveness of a new drug with a current standard method of care, experimental designs of exposure to high or low vitamin supplemented diets in studies of malnutrition, and comparison of omega-3 supplementation and progesterone treatment to prevent preterm delivery among women at higher risks for preterm delivery. In the first steps of an experimental study, the investigator begins with the target population, selects a sample from the population, depending on some selection criteria, determines who is eligible and willing to participate, and then applies a randomization scheme to the participants to allocate each person into either the treatment, intervention, or exposed, or the control, placebo, or unexposed group. The researcher then administers the exposure, a process that may or may not involve blinding. Blinding is a strategy used to reduce potential bias from both the investigative team and study participants by ensuring that the patients and investigators don't know whether participants are receiving a real treatment or a placebo. A placebo in clinical trials is usually a substance containing no medication that is given to mimic the treatment, so the participants don't realize they are not receiving the treatment. A sham is similar to a placebo, but is a fake procedure designed to resemble a real procedure that is being tested for efficacy. Sometimes a placebo effect is observed, which is an effect on patient outcomes that occurs because of the expectation of the patient, even though they are not receiving a treatment. Studies can be single-blinded, in which only the participants don't know who is getting a treatment or inactive treatment. Double-blinded, in which neither the participants nor the investigators know who is receiving the treatment, and triple-blinded, in which the data analyst is also unaware of who is in the treatment group. The goal of blinding is to keep human judgment or error out of the study to maximize internal validity. Participants are then followed over time to observe the outcomes that occur in both the treatment and control groups. In a randomized community trial, the design is similar in that communities are selected and randomized to receive an intervention or not, but typically stakeholders in these communities will have already agreed that they will be part of a trial before the randomization occurs. The intervention is implemented, and then communities are all followed over time to observe the outcomes of interest and to see if they differ between intervention and control communities. The difference between an RCT versus a community trial is that the unit of analysis in community trials is the group. Like in cohort studies, follow-up in randomized control trials is a serious issue and requires careful attention to prevent and track using as many approaches as possible. Loss to follow-up reduces the effective sample size because the investigators will be missing outcome measures on those who are lost. If follow-up rates differ among comparison groups and if attrition is related to the outcome, the results of the study can be biased. This is a special type of selection bias caused not by differences in enrollment, but instead by differential rates of retention that are related to the outcome. For example, a study on the efficacy of high-impact exercise on risk factors for osteoporosis had greater loss to follow-up in the group assigned to exercise. Women who dropped out may have had inherently lower bone strength that made the high-impact regimen less tolerable for them. If so, this would have produced selective loss of women more likely to develop osteoporosis from the active treatment group, and this would cause a biased estimate, specifically an overestimate of the benefit of exercise. When loss to follow-up is random or occurs equally between treatment and control groups, there is an impact on the ability to detect an effect size between groups. Results will be biased toward the null hypothesis or underestimated. When loss to follow-up occurs differently between treatment and control groups, we get bias in differential rates of retention, and this may bias our study results either away from or towards the null, which then exaggerates or underestimates the results, depending on which group is suffering greater loss to follow-up. Most experimental studies are cohort studies, so we use the same standard measure of association, risk ratios and rate ratios. Therapeutic trials often use the hazard ratio, which is essentially a measure of the probability of healing. As a brief reminder, the relative risk is an estimate of the risk of developing the outcome in the exposed group relative to those who are not exposed, and it measures the strength of the exposure-outcome relationship. The null hypothesis is that there is no difference in the risk of outcome in the exposed or treatment group compared to the unexposed or control group. Briefly, as we can discuss this more in depth in Module 7, this is a Kaplan-Meier curve representing time to symptom resolution or healing for the treatment group versus the placebo group in a therapeutic trial. Under the Cox proportional hazard model, the hazard rate ratio is the treatment hazard rate over the placebo hazard rate. The null hypothesis is that the hazard ratio is equal to 1, or that the treatment is not beneficial. It can be confusing to think of healing as a hazard, but when the treatment intention is to improve symptoms or end a negative outcome, it's the hazard of getting better, which is good. There are many uses for an RCT study design, including measuring effects of a controlled exposure on an outcome, testing, treatment, intervention, therapeutics, or any other exposure on an outcome. For planning, you have to think about how many treatment groups will you have. You may want to test a dose response effect on an outcome and have multiple treatment groups and a control group. But you have to calculate the sample size that you'll need to detect effects based on this number of groups. How will you randomize? You have to select a randomization scheme and how you will track and evaluate randomization. Will you use a simple random sample? Will you generate a list of random numbers and then assign study IDs of participants to those numbers, and then decide how those are allocated into experimental and control groups? There are many ways of approaching this, and we can talk about some of those in data collection, but you'll have to decide how you're going to randomize. How will you recruit and retain participants, which is an issue in all of our study designs? How will you administer the exposure, intervention, or treatment? What will you give to the control group, if anything? Often in experiments, it's unethical to give any kind of intervention to the control group if we are testing some kind of improvement on an existing intervention or a better treatment for something that already has an existing effective treatment. How will you measure the dose of the intervention and the outcome? What are your covariates? And how will you manage the different loss to follow-up scenarios? These are all things you have to consider when you're planning your randomized controlled trial. In summary, these are the measures, statistical hypotheses, and analytic models needed for planning an RCT, many of which we've just talked about. Loss to follow-up bias is the major concern in RCTs and must be prevented and closely monitored. However, because of the random allocation to intervention and control groups and the control of exposure, confounding selection and measurement bias are far less of an issue in RCTs than in other studies. RCTs can be very costly. It is expensive and takes a great deal of time and resources to plan and implement a randomized controlled trial and to maintain quality follow-up. They can take a long time to conduct if there's a significant amount needed to allow for an outcome to occur. But because of follow-up, you can measure risk or hazard. You can also measure multiple outcomes. It may not always be ethical or practical to conduct an RCT, so that must be taken into consideration, and you may need large sample sizes to detect statistically significant effects between groups. The randomized controlled trial is the gold standard of internal validity, but there is a steep trade-off between the restrictive eligibility often required for an RCT and the ability to generalize the results to the greater population. Finally, we'll talk about quasi-experimental designs. What happens if we are going to assign the exposure, but we can't or won't randomly allocate participants or communities to our exposed and unexposed groups? We have a quasi-experiment. We can also include pre-test and post-test designs in this group. Quasi-experiments are still experiments, but without the random allocation, they lose some of the internal validity of an experimental design. Quasi-experimental studies are often used to evaluate the effectiveness of public health interventions, quality improvement approaches, or policies. Because randomization isn't a requirement, they often reflect more real-world scenarios and can provide information on effectiveness of an intervention in practice. Types of quasi-experimental designs include pre-test, post-test designs with a control group, which is essentially an RCT without the randomization. You may also have a pre-test, post-test design in which there is no second control group, but the within group change is measured. And finally, you can have a post-test only design in which there is a control group. Here's our hierarchical diagram of a quasi-experimental study, and you'll see it's exactly the same as the RCT, except without random assignment. In this example of a quasi-experimental community trial, the design is the same as a randomized community trial, but there is no random allocation of communities to the treatment or control group. Communities are assigned to receive the intervention or not. Both groups are given a pretest or have the outcome measured at baseline. The intervention is administered to the intervention group, and the outcomes are measured at a given follow-up period, which is the post-test. It is the same design whether the trial is at the community or the individual level, reflected in this diagram. Fit for School is an example of a quasi-experimental, pre-test, post-test, clustered controlled trial, which means the interventions were delivered at the school level and outcome measurements were taken from a sample of children at each school. In this study, which was conducted in Cambodia, Indonesia, and Laos PDR, intervention schools were selected and a recommended nearby school was selected as a control school. There is no random assignment to intervention or control. The Fit for School intervention was focused on school-based hygiene practices like group hand washing with soap and toothbrushing with fluoride toothpaste, as well as construction of group hand washing facilities and biannual school-based deworming. Control groups implemented the deworming as well as a standard government health curriculum with a follow-up period of 2 years. Measurements were taken at baseline, pre-test, and at follow-up, post-test, in both intervention and control groups, hence the pre-test, post-test design. Results showed a significant reduction in adverse dental outcomes in the intervention schools, but no differences in the other outcomes. In a post-test only design with a control group, an intervention is implemented and potential outcomes are measured post-intervention in both intervention and control communities or individuals, it doesn't matter, but there are no data from baseline for comparison. An experimental pre-test and post-test design can be used to evaluate the effects of an intervention or policy change as well. In this design, the investigator is manipulating the exposure in that it is an intervention or policy, not a natural occurrence, but you are simply measuring some level of outcome, perhaps knowledge or access to resources or a specific disease outcome or behavior, in the study population before the exposure and then some period of time after the exposure or intervention, and the goal is to detect differences in the outcome before and after the intervention. The statistical hypotheses for all of these quasi-experimental designs involve detecting differences in outcome due to the intervention, some between intervention and control groups, or before and after an intervention. For those that are pre-post designs, you typically compare a mean difference within or between groups, and sometimes both within and between groups. In quasi-experimental studies, your measures depend on the design, but usually measure change and differences in means or standard risk and hazard ratios. But for complex studies, you'll likely implement some kind of regression modeling or GLM or multivariate regression. In giving up randomization, there's a concern for confounding and selection bias, but the reduction in measurement error stands, as in our CTs. Loss to follow-up may still be a concern in studies with longer follow-up time, but this more flexible design may allow for different approaches to follow-up, like in the random sample of participants in the FIT study. Experiments and interventions are expensive to implement regardless, but quasi-experimental designs are also very easy to do for program and policy evaluation. You are actually participating in a pre-test, post-test design each time you have a module training. And final thoughts, experimental studies are the most rigorous study designs, but their strong internal validity comes at a cost of generalizability. Quasi-experimental designs are better for representing real-world effectiveness, but sacrifice some internal validity by losing random allocation to treatment and control groups. Experiments are the one study design where we may make statements about causal relationships, but they can be costly and difficult to implement. Thank you.